My name is Daan Westra. I'm a PhD student at Maastricht University, the Health Services Research Department. I have a background in industrial engineering management and international business, and I'm doing my PhD research on competition in healthcare. So especially the Dutch healthcare sector has been reformed lately, or a few years ago, to introduce more competitive stimuli for both purchasers and providers. And we're at a point in time now where, especially for hospital care, 70% of all hospital services have what we call free pricing, which basically means that it's up to the hospital and the insurance company to negotiate a price for that specific treatment. So let's say certain knee surgery is in the free pricing segment, then an insurance company who contracts care on behalf of a group of patients is free to negotiate price for that specific knee surgery, which can result in the fact that similar surgeries have different prices in different hospitals. So we've not only introduced competition on a quality dimension, but also competition on a price dimension, specifically in healthcare or in hospital care. And that is the main topic of my PhD research. I've started working on this about a year and a half ago, and we've been specifically interested in how does such a competitive system, how does that influence hospitals and independent treatment centers in the sense of how they behave in the marketplace. So what we do is we basically take a cross-section of a hospital, which actually fits really nicely to the EHMA conference theme, because we decided, well, we need to take a cross-section of this organization, which ranges from bedside to board, or from board to bedside. And we've defined three interorganizational types which we're investigating at this moment. So we have these three types of interorganizational cooperation. One at board level, where we look at which board members work on the boards of multiple healthcare organizations. So we see in the Netherlands it's been a big debate also on, well, should we actually allow our board members to sit on multiple boards? And I think the current limit is set at 5 in what we've dubbed the governance code, which has also been discussed in one of the previous sessions here at the conference, the sessions on governance. And the second one is a cooperation at specialist level, where we look at specialists who work in multiple institutions. So for example, we can have specialists who work in a hospital and who simultaneously work in an independent treatment center, which is maybe in the same geographical market and might offer the same types of services as the hospital itself does. Or specialists who work in 2 hospitals which are close to each other, etc., etc. And the third one is actually patient referrals. So we try to investigate how, under a competitive circumstance, hospitals and independent treatment centers start to centralize the delivery of care, maybe to one hospital, where in a very pragmatic sense you would say, do we see that, for example, this hospital says, well, I'll do all the knee surgeries and I'll send all the elbow surgeries to the hospital next door. If I get the knee surgeries back sent back to me. So we investigate these 3 levels from bedside to board, where we say, okay, cooperation in terms of segregating the market in which services are provided, cooperation in the sense of specialists working in multiple institutions, and cooperation in the sense of which board members work where. And our assumption is here that in a competitive environment, allowing such links between organizations, or between healthcare organizations in this case, facilitates a certain dimension of knowledge flow between these organizations, which we view as a proxy of cooperation amongst them. And in a competitive healthcare market, you can ask questions about is this something that we want with competition? Is this how we intended competition to play out? The point that I'm trying to make is you can, on the one hand, introduce competition and expect that rigorous competition between provider might lead to optimal cost-quality ratio. But that doesn't necessarily mean that these optimal cost-quality ratios are an effect of rigorous competition and keeping your own competitive advantage for yourself. It could very well be possible, which is also what we see in our data, and what I've been presenting today, is that we see that under these competitive circumstances, we see these cooperative arrangements arise and flourish actually amongst healthcare providers, and especially at the board level, which was the topic of this session today. We don't just see this between institutions in the same care sector, so for example hospitals and hospitals, but we also see it in a vertical integration sense, where we see board members from home care institutions working on boards of hospitals, etc., etc. So these cooperative structures might be a way to facilitate knowledge flow and increase healthcare quality and healthcare outcomes, which is essentially, of course, the goal of competitive reforms, is to increase the quality of healthcare, so best possible care for affordable prices. So on the one hand, we are interested in, we have this competitive healthcare market, and how do healthcare providers actually react to these circumstances, which is one side of the story. And then the second side of the story as well, these reactions from providers actually create certain market structures, and which of these market structures actually leads to optimal patients' outcomes. Essentially, we are interested in, we make a policy at a macro level, which entices a reaction at the meso level, so at organizational level, and has an effect on micro level, so on patient outcomes. So the whole research line is focused on the interaction between these three levels, and can we explain behavior based on the competitive circumstance or the competitive policy that we introduced, and on the other hand, which type of market structure then leads to the best possible outcomes. So it goes a bit of back and forth, in the sense that on the one hand we say competition might lead to cooperation, which was maybe not the intended effect, but could be possibly a positive effect.